Hope you're all well and your families are keeping well.
Good afternoon, Betsy.
Good afternoon, Simon. Now, there's a message here from Claire Box that you're all seeing. It's an external participant having problems access the meeting, going to contact IT, and that's a lady called Jane Moore. And Jane is part of the team that's going to be dealing with the first item. The second item, access to dentistry. So we've got time to make sure that Jane, if she can get sorted. With that, I'll declare the meeting open. And first of all, can we have acceptance of apologies for absence? I've been notified within the last hour that Mrs. Mavis Harrison is unable to attend today, and Councillor Gillian Cruz has got a flat tire, and she's waiting for that to be dealt with. So I've wished her the best of luck in getting that flat tire sorted. Do we have any other apologies, Andy?
No, Chair, just the ones that you've mentioned. I've received apologies from Mrs. Mavis Harrison also.
Okay. That's acceptance of apologies. Item 2, under Chair's remarks, I'm going to welcome members to the meeting, and obviously the protocol for anybody listening in today, for the public or the press, is that when members of the committee today here wish to speak or pass comment or question on the agenda, they will indicate on screen, and they will be taken in turn to question the meeting or the representatives here today. The rules of debate are accordingly with that process. I would encourage members just to use the question and comment box, and messages as brief as possible. We're not in a chat room as such. So with that, I'll go on to the Chair's remarks. Since our last meeting, obviously I've had a meeting recently with Councillor Mrs. Faith Heptonstall. Faith is the Cabinet Member for Adult Social Care, and Nicola Esmond from our elderly care team. And the main issues discussed were the care homes, the CQC inspections, which is on our agenda today, hospital discharge, and mainly focusing as well on the discharge from hospital to home. I know we've covered the residential home in terms of the capacities and policies there, but I thought it was advantageous that we should make sure that our discharge to home was adequately supported in terms of the individual going home, whether it was step down procedure, re-enablement, etc. And there was a good discussion on that. And that followed then with a discussion about the budget for social care for the next financial year. As we all know, one of the main things in the budget that we're having to address continuously, due to the lack of the government bringing forward the white paper on adult social care, is the increased demand and indeed the increased cost. One of our priorities obviously is to maintain people in their own home as long as possible. In line with other budgets across the authority, they are having to look at making some savings as well in areas that we hope will not impact on our policies of care in general. So it's a very good, useful meeting, and hopefully today, when we have our CQC colleagues here, we're all going to get added value from the information they're going to give us today. With that, I'll go on to item 3, which is the member's declaration of interest. That's the usual format. If there are any declarations of interest, can you declare them now? If there are no declarations of interest there, are there any that would be personal or prejudicial, financial? I'll take that as a no, thank you. And that takes us on to item 4, to note any items which have agreed to add to the agenda on the grounds of urgency. I have none. And item 5, is to approve as a correct record the minutes of the meeting of the Adult Services, Public Health and NHS Overview and Scrutiny Committee held on the 25th of February 21, pages 1 to 5. And just to say that most items on that particular item from that last meeting are covered on today's agenda. So with that in mind, can you agree that we take those minutes as a correct record?
Move them, Chair.
Thank you.
Second them, Chair.
Thank you. If I don't hear anything against, I'll take that as you're all agreeing. Thank you. That takes us on to item 6, which is the Care Quality Commission inspections, pages 7 to 25. Could I welcome Helen Harris, CQC Inspection Manager, Kirklees and Wakefield, to the meeting. Also in attendance today is Nicola Esmond, which is our Adult Services Director. Can I welcome you both to the meeting and thank you for your attendance. Today's meeting will focus on the Care Quality Commission's role where there is inadequate care. There are concerns around those providers who appear to show little improvement, particularly those who are placed in special measures. There may be a misconception that nothing seems to be happening in between inspections to bring about the necessary improvement, and we've all had thoughts on that one, or that the CQC are slow to use its enforcement powers. The primary concerns are around quality and safety of residents who remain in placements where the provider is in special measures. It would be helpful today from our representatives here to reassure members, particularly around safeguarding and the multi-agency work that's undertaken to support care homes to make the necessary improvements. By way of process at the meeting, Helen from the CQC will present an update from them, including the role and purpose of the CQC. COVID-19 Wakefield ratings, what is a closed culture? These are all part of the report that you've seen. The regulations that had to be dealt with in the pandemic, and of course, hopefully, please God, the next phase, which will be responding to risk and, as we all know, in a changing world, the new ways of working, which will be reporting findings, etc. I think that this is going to give members an overview of what the CQC approaches and how they approaches inspections and regulation, in particular as we've all had concerns in relation to poor or inadequate care. Nicola, welcome to the meeting. We'll supplement this with an overview of those providers who are in special measures or a cause for concern. You'll be then able to focus your questions about the CQC and in terms of the establishments identified. I'm sure you'll want to know the level of risk that's considered when making judgments about these providers, and particularly those that are placed in special measures. And at this point, I'd like to hand over to the CQC, who I'm sure will also be consider and at what point the suspension happens of the providers in terms of the registration. I think it's going to be very useful today, and with that I'm going to hand over to Helen and Nicola. Welcome, Helen. Are you going to be the one that's going to present the report first?
Chair, can I just interject at that point? It seems that Helen is having a problem getting into the meeting.
Okay.
Apparently she's got software problems. This tends to happen when we have external participants who use different systems, unfortunately.
Exactly.
But she's actually asked, and I'm not sure if this is possible, so perhaps our IT colleagues could advise whether or not she can actually phone into the meeting. And if I have an audio contact, if not in terms of visual.
That's fine, as long as you can participate in the meeting. But I have another message here. It says Debbie Pattinson of NHSC. Unfortunately, I can't get into the meeting other than to see a list of participants. The message I'm getting is audio cannot be connected. So is this applying to Helen and Debbie as well?
It seems like we're having multiple problems this afternoon.
Multiple, okay. Well, I'm sure members will agree. We've got a lady called Julie Owen typing a message now. Yeah, when we fragmented platforms like this, it is a particular nuisance. I'm sure colleagues will agree that whatever format the representatives can actually get to attend our meeting, we can agree to that. I'll take that as a yes. We've had no objections. Now, while people are trying to do that, would it be useful, Andy and members, if we just had Nicola? You're here, aren't you? Nicola, can you hear me?
Yes, sorry, Chair. Yes, I am. I was struggling to hit my mute button in a bit of a panic, but yes, I'm here.
Okay. Well, while our other colleagues from NHSE are trying to get into the meeting and participate by phone, we'll have to see how that works out. Would it be okay, Nicola, if you were sort of to give us a little bit of a picture while we're waiting for them to get in?
I can, Chair, yes. I'll just give a brief overview, I guess, of how we work as a system with the CQC. I'm aware that members heard quite a detailed presentation last meeting, so I will talk until you tell me to stop, Chair, if that's okay, while we're letting Helen get in by some other means.
That's fine. Thank you, Nicola.
Thank you. So, yeah, just to remind everybody that it is a joint process when we have a provider that is struggling, and it's generally managed through the enhanced quality surveillance approach that is led by the CCG, and Laura Elliott, our colleague, is on the call as well from the CCG, working really closely with the CQC. So the enhanced quality surveillance at the moment has 3 homes on that are rated inadequate by the CQC, and 4 homes that are not. There requires improvement, but we are aware of some additional concerns with those homes, so we are paying a bit more attention to them than we would usually do. And then there is 1 domiciliary care provider on that list at the moment that we are also that is also under enhanced surveillance. And those providers are subject to regular scrutiny from all partners, updating one another as to the various different actions we've taken. Because one of the things we have recognised is it doesn't help a provider if they're required to provide action plans for the CQC, for the CCG, for ourselves, and all the rest of it. What they need is us to support them to improve, and when the point comes where we feel that they are not improving, then we would work together to take whatever enforcement action or remedial action that we think is necessary. Is Helen still not on the call, Andy? No, I'm assuming not. So the presentation that Helen is going to give is a much more detailed focus on the CQC part of the roles that are played, and a bit of an update on where they are in the new way of monitoring providers, because obviously with COVID it's all become much more difficult. We don't get that foot in the doorway as much as we have done previously, and we don't have the sort of insight from visitors and as many health professionals visiting homes, so we are aware that it's a bit more difficult for us to get a better view of what's going on inside the care homes than it used to be.
We're still having problems, Nicola. I'm sorry, we'll still not be able to get Ellen to get into the meeting.
We're still having problems, so at the moment, maybe a way forward might be just if our colleagues are available to start with the dentistry report while we can see if the CQC can actually get established.
So Councillor Rhodes, it's Anna Hartley speaking. So unfortunately, a number of our dental colleagues who've prepared quite significant presentations are also unable to get onto this platform. Skype does appear to be a real challenge. I don't know, Andy, whether we could resume, well, whether there's an option to use Zoom at a future meeting. I'm just thinking it's a real shame because we've got Joe Hendren and a number of NHSE colleagues who've spent a lot of time and energy today pulling together a really really detailed presentation. Obviously they can't even get on the call, let alone present it. And unfortunately we have had this issue many times with Skype because it is such an old platform. So I don't know what the options are, because obviously, Councillor Rose, it's vital for you and your committee that you do get that proper picture, not just from council staff but right across the system, in order to give you that assurance. Oh right, okay, brilliant. But Joe definitely wasn't hearing. I don't know if you are now yet. So Joe, I don't think Joe's got audio, because like he's got that little phone thing with the red line through it. So Joe, can you hear us? Okay, well, we could just do some of the talk. What would you prefer, Councillor Rose? Would you prefer that we do some of the presentation, or would you, what would work best for you?
Right. Okay. There was an offer of using a telephone link. Is that not available? Andy, can you hear me?
Yes, Chair. I'm not sure that it is, to be honest with you, and I entirely agree with Anna's comments regarding the platform and the problems we've had in the past. Obviously, at some stage this will need to be reviewed and obviously rectified. I know the council is moving towards a different platform, but we're not quite there yet, I don't think. And as a consequence, we're still using Skype and the problems that presents. So in terms of what's been suggested, I mean, if we can retain this item on today's agenda, then that will be the ideal situation. But clearly, given what Anna said in terms of the participants who are contributing to the item, it will be difficult to get a full picture and input from them if we can't actually get everybody on the platform as it stands. So obviously, Chair, it's a matter for the committee in terms of whether or not we proceed on the basis of limited availability of participants, or we actually continue at another date and arrange a further meeting with another platform if that's possible.
Well, I was just thinking something that's actually come up on a message to us here, saying we can move to Zoom if you want to set up the meeting. Is that you, James? No, it's Gregor Jones. Gregor? Okay.
Hi, can you hear me?
Yes.
Yeah, so I can set up a Zoom meeting and we can test it through that method if you want.
Well, I think if that's possible, rather than defer.
Right.
Okay.
Right.
Public
Yeah,
system is going to be.
I mean, Councillor Rhodes, given that Rachel's here from Mid Yorkshire and Julie's got some slides, shall we do the best we can, and then we can always come back to a future meeting with some additional information.
Oh, we've got Sandra Whiston, okay. We've got some people now are actually able to get in. That's good news. So let's then move on. And I'm sure that as we go along, what it really does today, to introduce yourselves, then we know who's actually in attendance.
Will I go first?
Yes, please, Joe.
Yeah, Joe Hendren. I'm a general dental practitioner in Wakefield. I also chair the Wakefield and District Local Dental Committee, and we represent some 39 practices across Wakefield District, and over 100 dentists are involved in that. And I'm here to speak about general dental practice.
Thank you, Joe. Who's accompanying you today, Joe?
I believe Rachel Nichols on the line. She's paediatric consultant at Wakefield Community Dental Service. Pass over to her.
That's
Yes.
it.
Hi, I'm here, and I'm going to present after Joe. As Joe says, I'm a consultant in paediatric dentistry in the Community Dental Service. I'll explain a little bit more after Joe's presentation.
That's brilliant, Rachel. Thank you, dear. And before we go any further, I'll have to do as I did the last time when Joe attended our committee. I have an interest in my teeth because I am a member of a patient, I should say, of St. Michael's Dentist Practice down the road. So with that, Joe...
Sorry, there's also a number of public health staff here as well for this item, including myself, Anna Hartley, Director of Public Health.
Yes, I know.
I'll get people to just type their names in the chat so as not to take any more time up.
I've got 35 messages in there, so I would prefer when they're introducing themselves after you, Anna, then we'll just have the names. We'll concentrate on the report.
Yeah.
So, Anna, you are going to introduce the report and then you're going to hand over to Joe.
Yeah, and I will do that very briefly by saying we're now going to hear from Joe.
Good girl. Thank you very much, Anna. Over to you, Joe.
Thank you, Anna. I'd just like to thank the Council Oversight and Scrutiny Committee for this opportunity to address you. It's the first time that I've been able to do so since the inception of the Oral Health Advisory Group in 2014. So it's nice that we're able to put our position to the council members. I sent in a report of what's happened and the situation in primary dental care within practices across the Wakefield district, and I trust that everybody has read that. I'm happy to take questions on it. But moving on to the next slide, please. So currently all practices are open and we're prioritising urgent dental care. Also those vulnerable patients who need care more urgently than others who will be more considered more stable. And also we're still going through the open courses of treatment that were in place during the first lockdown. The reason behind the delay in completing those courses of treatment is because we're restricted in the numbers that we're able to see due to the social distancing guidance, the standard operating procedures that have been produced by NHS England, the Chief Dental Officer and the Faculty of General Dental Practitioners, and the increased time that it takes that we need to prepare surgeries between patients in order to address the increased infection control procedures. Much more in-depth cleaning now because of this pandemic and the virus that's all around us. So on the slide there it says we're providing 45% of contracted activity. That was the case until the 31st of March. NHS England has instructed us that we are to provide at least 60% of contracted activity going forward for the next 2 quarters of this year. And we're starting to see an increase in routine children's examinations. We consider children as being top of the priority list because they're much more susceptible to dental decay problems, and they really need to be addressed first. We're quite aware that with children being off school and staying at home longer, that normal habits have changed, and there's been an increase in sugar intake and a change in the dietary routines that children would have outside of the pandemic. Also, prior to the pandemic, significant numbers of practices had not been accepting new patients as they had reached capacity. This is due to the NHS dental contract, which has a limited budget and a limited activity, and even if practices were able to take on more patients, if they had fulfilled their activity targets, then it would not be in their interest to take on additional patients because they don't have that activity to pay for the treatment that would be entailed. Next slide, please. Wakefield, one of the big concerns for dentistry and that the council should have is that the most significant reason for children to be taken into hospital is to have teeth removed, and this is a preventable disease, and it is something that any new dental contract which we're in the process of developing should address prevention. And it's also something that the council, in their responsibility for dental public health, that the prevention element should be brought much more to the fore. And as a result of Wakefield being deemed one of the highest areas for oral health deprivation, NHS England and the CDO decided, the Chief Dental Officer decided that they would be one of the 10 areas where a starting well project would be situated. This started back in about 2017-18, and 10 practices in the east of the Wakefield district have been involved and had received some support from NHS England from a financial point of view and an organisational point of view. Children have been identified by health visitors in the 0 to 19 team who did not have a dentist. These then were passed on to the starting well practices for ongoing care and advice. Some of these practices continued post the support when the starting well project finished. Some practice continued to provide this service and collaboration with the 0 to 19 team up until March 2020, when things had to close down because of the pandemic. It's really important that this process is reinvigorated as practices are able to increase their ability to provide access. Next slide, please. For the last 18 months, local dental committees across Yorkshire and Humber have been working with NHS England in Yorkshire and Humber specifically to look at different ways of trying to deliver dental care. And this concept of flexible commissioning has been brought up so that 10% of normal surgery activity, drilling, fillings, gum treatment, extractions, dentures, would be exchanged for more prevention delivery. So the delivery of fluoride varnish to children and adults, oral health education and promotion, also providing access for more vulnerable groups, including adults. And participating practices should be clearly seen to be accepting new patients. That is the number one requirement to be involved in this flexible commissioning process. But unfortunately, again, because of the pandemic, that's taken a back seat. But now that we're starting to get back to normal processes, flexible commissioning, or as the Chief Dental Officer now calls it, transitional commissioning, is coming more to the fore. And Yorkshire and Humber are leaders in this from a national point of view. So on to the next slide. So the future plans for the NHS, we're probably all aware of the white paper on the integrated care system approach for delivering healthcare in the future, which draws together healthcare and social care. But there's been very little mention of oral health and where the dental practice fits within the role of primary care networks that make up these integrated care systems. Health and local authority commissioners need to really define how they want to see oral health improve in their areas and help to provide mechanisms to deliver the improvements that need to be seen. One of the most notable aspects with regards to dentistry, with regards to the white paper, is the point on community water fluoridation, and it looks as though central government is going to be taking over responsibility for this, taking responsibility away from the local authorities. I appeared in front of the Oversight and Scrutiny Committees 4 or 5 years ago in order to try and persuade the council that water fluoridation is a necessity to improve the dental public health of the community. Unfortunately, that was not followed up on, and I do strongly feel that the waiting list that Rachel is going to come on to talk to you about would be at least 30% less, especially with the 0 to 5-year-olds, if we had water fluoridation. It is without any doubt the strongest evidence that this helps to improve the dental health of our young people and also our adults, because the fluoride in the water gets into the adult teeth as well as the children's teeth, and would possibly have reduced the amount of urgent dental care that we would have had to provide during the lockdown, during the period during 2020. Going on to the next slide. So I've been involved, as I said, with the Oral Health Advisory Group of the Council since 2014. And in 2015, we helped to develop an oral health improvement plan. But unfortunately, this expired in 2018. And I would call that we would revise this and develop a similar structure with aims and aspirations as to how we feel that we can improve the dental health of the Wakefield population. Looking through the documents from the council, there was no mention of oral health in the Wakefield Health and Wellbeing 3-year plan in 2018. And I find it's not only Wakefield that's doing this. I'm looking at integrated care systems, the West Yorkshire and Harrogate one. Very little mention of dental care or oral health is being mentioned in this. And this is something the Oversight and Scrutiny Committee should really take quite seriously. If they want to improve and reduce the level of pain and infection in young people, then some sort of much more preventive approach, oral health promotion, must be a key aspect of improving this level of public health. So that all stakeholders, local authorities, public health, NHS England, local dental committees, the Community Dental Service should all be involved in a renewed strategy to oversee the oral health improvement for adults and children. And that's concludes what really I have to say on this. I'm happy to take questions after. I'll pass on to Rachel Nicholl, if that's okay.
Hi. So many thanks for inviting me. I'm delighted to be able to speak to you all about the community dental service and how COVID-19 has impacted us. So the community dental service in Wakefield is part of Mid Yorkshire Hospitals NHS Trust. We have clinics in Wakefield, Castleford, Pontefract, South Kirby, and also see psychiatric patients at Newton Lodge Fieldhead Hospital. So that's just a little bit of background. The other thing to add is that we have two dental specialties working within the community dental service. I am, as I've said, I'm a consultant in paediatric dentistry, and we also have special care dentistry for adults in the service. So just a little look at our timeline and activity throughout COVID. We didn't ever actually close, and we opened as an urgent dental centre on the 27th of April. So what that means is from when COVID started, we carried on seeing our own patients, but only on a very strict basis of those that absolutely had to be seen due to pain or infection. On the 27th of April, we opened as an urgent dental centre, so we started accepting patients that weren't our own, but who would fit our acceptance criteria. And that generally is children or adults that cannot be seen within the general dental service due to additional needs that they may have. All general anaesthetics ceased in March of 2020. Prior to that, we had 2 general anaesthetic lists a week for children to have teeth out. We had 1 general anaesthetic list a fortnight for children to have comprehensive dental care, which is where they can have fillings and extractions. And we had 1 list a fortnight for adult special care dentistry. I fought very hard and managed to get my first general anaesthetic list back on the 5th of June. However, to date, we are still only at 40% capacity for paediatric general anaesthetic lists and 0% for adult special care lists. Face-to-face appointments, we are getting there. As Joe has mentioned, we can't get back to 100% capacity because of the enhanced infection control procedures, the social distancing that we need to abide to. But we're there at 78% for adults and 86% for children, comparing our activity over the last 3 months with the same time last year. And we're doing quite a lot of face-to-face consultations. So we're doing a lot of check-ins rather than check-ups. So what this means is we contact patients by telephone, ask them if they're having any problems. We can often do this via video consultation as well. And especially those more vulnerable patients are really appreciating this contact and reassurance. And we will then see them face-to-face if the patient wants to, or if we think it's necessary. Due to our huge decrease in general anaesthetic capacity, we've been providing a lot of treatment under inhalation sedation within our clinics. So this is gas and air effectively. And we've managed to train up during COVID another 2 dentists that can provide treatment using this modality. Next slide, please. So our referrals are now increasing. They certainly dried up for a little bit as the general dental practices weren't open. They therefore weren't referring as any patients. But we're now back up to 90% for children and about 50% for adults. Prior to COVID-19, I compared our referral rates from October 18 to January 19 with October 19 to January 20, so before COVID skewed our results. And in this time, we'd had a 40% increase in paediatric referrals, and the majority being specialist level. So that means needs to be seen by a specialist or a consultant in paediatric dentistry. So we've seen a huge increase in paediatric referrals. And part of that is because of my appointment to the service in 2019, which meant the children of Wakefield district didn't have to travel to Leeds Dental Institute to receive specialist care. So that is a great step forward. However, it's put pressure on the service. And we've also very recently seen a huge increase in referrals from school nursing teams, and this is due to families not being able to access a general dentist. Next slide, please. So looking at the impact of COVID, on my slide, you can, it's not overlapped, so I'll just talk you through that. For new patient consultations for a routine referral, so this is generally a routine referral will be classed as someone that isn't suffering from pain or infection but has dental disease. and that dental disease won't have an impact on their general health. So we're looking at an increase in February 2020 from referral to assessment. We had a 6-week wait. Move on 12 months, we have a 57-week wait, so a significant impact there. Looking at our general anaesthetic lists, from assessment to treatment for our adult special care, you can see we've moved from 15 weeks to 74, paediatric comprehensive care from 13 to 59, and for extraction only, we've moved from 1 week to 69 weeks. So a huge impact on our waiting list. And it's worth reiterating what Joe said about general anaesthetics for dentistry. In England, there was approximately 42,000 children aged up to 16 who were admitted to hospital in 2018 to 19 due to dental decay, making it the most common reason for children to be admitted to hospital, an estimated cost of well over £50 million a year. And this is, as Joe said, for a largely preventable disease. We are seeing far more children in hospitals having general anaesthetics for dental reasons than other common childhood operations such as tonsillectomies, for instance. And what is also on my slide here is that we have a new prioritisation system in place. So although our assessment waiting times are immense at the moment, I'm very pleased we are seeing the children and adults that need to be seen through a very strict prioritisation and triage system. So anybody in pain or infection we are seeing very quickly. Your routine referrals are having to wait a very long time at the moment. Next slide, please. So as Joe has already said, prevention is key. And it was a real shame that unfortunately we lost our oral health promotion contract in 2017. The epidemiological survey was previously held by Wakefield Community Dental Service, but that was given to Bradford CDS in 2015. So currently, with regard to prevention, we're only really able to carry out in-house preventive advice and measures, which includes applying fluoride varnish and all the preventive advice according to a Department of Health document called Delivering Better Oral Health. We have got a remote prevention programme in development where we contact patients by telephone and give all the preventive advice this way. And the other provision we've got is that all general anaesthetic patients who have a sibling aged 0 to 5 are referred to the 0 to 19 service for preventive input from the health visitor team. So that's all we can do at the moment. It's a real shame we lost the oral health promotion because, as I say, that really this is key. And I think the return on investment is there. It's been shown by a Scottish programme called Child Smile that the prevention, it works, it decreases decay, and there is a good return on investment. That's my last slide, but very happy to take any questions at the appropriate time. Thank you.
Thank you, Rachel. I see that we've got Sandra with us as well. Sandra Whiston, you're here and you're able to present. Do you want to continue on from Rachel, please?
Chair, it's Julie Owen from Public Health. Sandra's presentation will follow directly. We just wanted to present the committee with some information from Oral Health in terms of prevention, and then Sandra will be able to talk about Public Health England and some of the work that they're doing. Is that okay?
Yes, fine, continue.
Thank you. Just referring back to the information that Rachel shared in terms of prevention and the changes that were made to the commissioning of prevention services, what that did result in is investment in the areas particularly around the 0 to 19 service, and my colleague Melanie Robinson will be able to tell you some more about that. And I can tell you something about the supervised toothbrushing scheme that we have in place. So Melanie, do you want to talk about the 0 to 19 service?
Yes, thank you. The 0 to 19 service is our health visiting service, which is commissioned through Public Health. They have been mentioned a few times throughout the presentation by Rachel and Jo, and continue and have continued to provide support to families during COVID. COVID and the pandemic has affected the delivery of support, but every family presently receive a face-to-face visit between following the birth and the first 6 to 12 weeks, and at those visits the health visitor provides the dental pack, which contains a toothbrush and fluoride toothpaste, and they have also a face-to-face discussion about healthy gums and healthy teeth and how to promote healthy teeth. The enhanced dental offer due to the service during COVID has been restricted, but following a recent meeting where Jo, myself, Julie, who's just been speaking, and Rachel were present, that is able to resume, in dentists being able to refer more now into the health visiting service. So things are progressing well. And I'll hand you back over to Julie in relation to the supervised toothbrushing scheme that has also been funded as a preventative tool.
Thank you, Melanie. And yes, the supervised toothbrushing scheme is based in nurseries, being led by a community organisation working with St George's. We established the scheme in the hopes of embedding good oral health at a very early age and good oral health habits in very young children. Unfortunately, due to COVID, national guidance was that such schemes, that we should halt the introduction of new schemes into other nurseries. So there's been a hold on that. St George's have continued to do dry toothbrushing because of the COVID concerns. We're hoping, as there is a relaxation of some requirement, and that we might be able to revisit the revive the supervised toothbrushing schemes and the rollout of that to other nurseries around the district. But we're to look at maybe enhancing that model in terms of getting oral health messages out into our communities. The oral health in care homes toolkit came out in February from nationally through Public Health England, a very useful resource for care homes, but it also includes a resource for commissioners. So we are having conversations with commissioning colleagues about what we might be able to include in the future commissioning framework around good oral health for residents living in care homes in the district. In terms of the epidemiological survey, Rachel is right that Bradford now provide that survey for Wakefield, and that's a joint commission with Calderdale and Kirklees. The 3-year-old survey was suspended early this year, but I'll hand on to my colleague Sandra Whiston from Public Health England, who will be able to talk you through some of that detail.
Thank you. My name is Sandra Whiston. I'm a consultant in dental public health with Public Health England, Yorkshire and Humber, and my role is to support the local authorities and NHS England around their commissioning responsibilities around oral health. I'm struggling to see the shared presentation, but I have my slides in front of me, so as long as I know that we're starting from my title slide, is that what everyone can see?
We've just moved on to the second slide, Sandra.
So we're on to slide 2 now, are we?
Yeah, the National Health Service.
Thank you.
Paper.
Okay, so I was asked today to talk to you around and give you an update on the two of a local authority's oral health responsibilities. So you've already heard oral health promotion, and I'm going to talk to you about the oral health survey programme and an update on the water fluoridation, particularly with respect to the white paper.